walk right now, the elevator, bring it up, but you'll just be on that speaker and you just walk out.
So the speaker is like,
And I talk to them, I'll tell them 2 minutes and I'll count it down.
and then let me know when the 2 minute card is.
Everybody will know.
Don't let them come out.
Oh, you want them here? You want them here?
I have to roll for 2 minutes on like show me how and then it's gonna come out. Oh. We got just 2 minutes to free. You want to do that now?
No, I think they're gonna do one.
Oh, okay. Okay, then I need 2 minutes.
Okay.
Before the start of the program, and after that, it's 5:15. Okay, 5:15. Roll.
Okay, we're at 5:55.
That's right, yeah. I'm yeah.
Yeah. Tuck that in like, put it in your pants or where it looks nice and neat. Yep. Yeah. Phone's off, isn't it?
Yeah, that's right.
And the woman we're talking to before, she's going to do the introduction. Just so I can look for her.
Thanks for coming. I didn't reply. We're gonna all go to grab some food after if you want to. Hey, how are you? Good. You just came back, right?
Yes. I was up over the line with
Oh, nice. Right. What's new? 2006. She was
I sit
2006.
here so that I can.
Yeah. So she's good. I think she's good balance there. She's happy. So it's beautiful. Down more. Kind of like a little bit outside.
I'm counting it down, and I'll let you know.
I know.
2 minutes to generally walk up there and do your thing.
All right, so we've got about 2 minutes.
Over here. How's everything? Oh, thank you.
Yes,
Good.
we thank him for recommending you, Daniel.
Baligh.
Hey, how's it going?
I'm good.
You doing all right?
Yes, sir. A little talk here.
Okay.
And 1 minute away. Seconds.
I did not know that you got them fixed.
10 seconds. And start.
Welcome. I'm Gail Sassnett. I'm Associate Director of the Bob Graham Center for Public Service, and we are so glad to see all of you here. Lots of students, that's terrific. I'm going to remind you that at the end of the program, we will have audience Q&A. We will have a microphone right here on a stand, and we will ask you to come to the microphone since we're streaming and recording this event. And I also will remind you to turn off your cell phones. Tonight, we are so grateful to the VA for recommending and putting us in touch with our speaker, Dr. Yehia. Mr. Thomas Wisniewski, who is the director of the North Florida, South Georgia Veterans Health System, is here to introduce him. Mr. Wisniewski.
Thank you, Gail. Good evening, everybody. And it's my distinct pleasure to introduce Dr. Yehia. And Baligh, because we go back a ways, is a change agent experienced in leading change in complex healthcare systems and networks. He is committed to improving the patient experience and drives initiatives focused on clinical care, quality improvement, and systems redesign, now at the Johns Hopkins Medicine. At VA, Dr. Yehia led the department in its transformational journey to provide veterans with easier access to both VA care and private sector care. He oversaw the VA's community of care network, which includes about 500,000 providers, academics, and community networks, and expanded telehealth across our vast system of care, treating about 1.5 million patients annually. A significant improvement that was done in terms of providing access to care and increasing access to care for veterans. He is a nationally recognized expert in HIV medicine and health equality. Dr. Yehia has published over 150 abstracts, chapters, and white papers in leading journals. He has made important contributions to the understanding of patient engagement in healthcare and individual and environmental factors influencing access and participation in care. Dr. Yehia is board certified in internal medicine and infectious diseases. He received his bachelor and medical degrees right here at the University of Florida. He has also completed internal medicine residency at Johns Hopkins Hospital and an infectious disease fellowship at the Hospital of the University of Pennsylvania. He also holds a Master's in Public Policy from Princeton University and Masters of Science in Health Policy Research from the University of Pennsylvania. Please join me in welcoming Dr. Yehia.
You guys hear me all right?
Yeah.
All right. Well, it's really a pleasure to be here today, kind of bringing together my undergrad and my medical school training here at the University of Florida, my work with the VA. So it's really a little bit of a homecoming to be able to be here. So thank you for inviting me, for having me. I'm looking forward to our conversation today. Really what I wanted to share is a couple of thoughts about how healthcare is changing in America today, and really draw on lessons from the Department of Veteran Affairs and how other healthcare systems and networks can really use those lessons to continue to drive forward positive change for patients and for providers, and really for the population at large, which is really the title of our talk today, which is really how you take ideas and put them and implement them into practice and lead change in healthcare. So I just want to first set this up for us tonight, is really talk about what is changing in healthcare, and have you think about that as really as the context for our conversation today of how to lead change in healthcare systems and networks. So the first is really to think about how our population is changing. Many of you know that our population is aging, and as part of that, more and more of our patients that we take care of in clinics have multiple chronic conditions. And so if you think about, this is data from the Agency for Healthcare Research and Quality, AHRQ. In 2010, about a third of Americans had more than one chronic condition. And over the last 5 years, it's been a 4% increase. So that's from 2006 to 2010. So what does that mean? That means when you walk into a doctor's office, you're more likely to have more than one condition that doctor has to take care of. And that also might mean that you have to work more with different specialists to coordinate that care. So we are seeing that multiple chronic conditions are on the rise. We also know that over time, that to be able to manage those individuals, we have to rely on more than one provider, more than one specialist. And so what this graph shows you is that both in the primary care world and in the specialty world, the number of referrals, the likelihood that that patient would leave an office with a referral to see another doctor has been rising over the last number of years. And so you can see that, again, this means that there's multiple providers that are involved in delivery of healthcare, not just one primary care provider or one specialist. We also know that healthcare is now delivered in multiple settings. You can walk to a grocery store, you can walk into a pharmacy, and you might be able to receive a flu shot, or someone might be able to check your blood pressure and even prescribe medications for you. So that's very different than what was occurring 10, 15, 20 years ago. The era of just clinics and hospitals has really been expanding. Telehealth, or how you actually communicate maybe through a smartphone or a computer at your house to deliver healthcare, that wasn't around before. So the venues where you can actually receive healthcare has also changed. So what does that mean? And I wanted to give just one example, thinking about opioids, which I know is probably on a lot of our clinicians' minds these days. We've seen over the last number of years the number of opioid prescriptions, and this is data from Medicare, that are prescribed by more than one provider has been on the rise. So in 2010, only about 40% of Medicare beneficiaries, and this was about a million people that they looked at, had a prescription from one provider. I mean, 60% had prescriptions from more than one provider. And when you look at those that had four providers prescribing, the likelihood that their prescriptions overlap was about 70% of the time. So you can imagine that's a problem. If you have two prescriptions and those medicines are very dangerous, and it can result in bad health outcomes. And in fact, that's exactly what happened. The more prescribers that you have, the more likelihood you are to get admitted to a hospital because of use of those opioid prescriptions. So this really starts to highlight as a little bit of a case in point of more providers, more settings, more chronic conditions that might have pain, and this is one example of what we want to make sure we avoid and prevent as we think about creating change in healthcare. You know, one thing that has been around for a long time that really hasn't received the attention that it deserves is really thinking about the social determinants of health. And if you look at the graph on the left-hand side, you can see that healthcare, so if someone comes to see me in clinic, the contribution that I make to their overall health is only about 10%. Their genetics, their behaviors that they have at home, the environment that they live in, their social, economic, and legal situation, all of that has a much bigger impact on their health and well-being than a prescription that I might write in my office. So that's really important as we think about how do we improve the health of populations and our communities across the country. That means we don't just need better medicines and better treatments. We really need to think about how we can get out there in those communities and make sure that we're able to address what we call the social determinants of health. And one way of doing that is something called the health in all policy, which means really every policy that we pass, whether it's at the local level or the national level, will have some impact on the individual's health, whether it's transportation and how quickly you're able to get between your home and a doctor's appointment, whether it's agriculture, whether it's environmental policy, all of that really impacts the health of our community. And so the CDC and others have been promoting health in all policies. Think about the health impact of the various policies that local all the way up through national governments might be working on before you actually implement them. And this kind of goes a little bit without saying, the cost of healthcare and the cost of treating these multiple chronic conditions is definitely on the rise. You can compare and contrast here between 2006 and 2010. The cost of treating patients with 5 or more chronic conditions is on the rise. And again, it's very interesting when you look at the proportion of healthcare dollars that we spend for those individuals with multiple conditions. They overwhelmingly make up that burden of cost. So I'll give you an example. For those individuals with 5 or more chronic conditions, they only represent about 8-9% of the population, but they make up 35% of the healthcare costs that America spends on the dollar every year. So really what we need to do is focus on how we can better coordinate that care, how we can better manage those chronic conditions, and it will start to help bend the cost curve. The last couple points that I wanted to make before we get into the meat of our conversation is really the rapid change or the rapid pace of change in healthcare. So we talked about multiple settings, we talked about multiple providers, multiple chronic conditions, and the cost of those conditions. Well, healthcare has been changing very rapidly in the last couple of years, so this is not just something that's been happening over decades. Here's a perfect example. The movement from what we call volume to value. Right now, many healthcare providers in the country get rewarded by what we call fee-for-service. They get paid for their time, they get paid per appointment, but they don't necessarily get paid for the outcomes that they're delivering, the health outcomes that we want to see in our patients, that they're stayed out of the hospital, that their diabetes is under control, that they have a good blood pressure. So you can see that in 2016, the Centers for Medicare and Medicaid Services, CMS, 30% of their payments to doctors in that year were based on value, which is a very large increase and only going to grow over time. One of the ways that they can deliver that value proposition is through something called accountable care organizations. And these accountable care organizations have been growing very rapidly, and the graph here shows from 2011 to 2017. We now have about 923 ACOs across the country that cover about 32 million Americans. Well, that's 10% of the population. That's a huge increase in a number of 5 years. And so you can think about not only the change that's occurring, but how fast that change is occurring. I'll give you 2 other examples. One is on FDA drugs that are approved. You can kind of see the sharp line there. Over the last decades, the number of new drugs that the FDA approves for the treatment of healthcare has been rapidly rising. And interestingly, for hospitals and healthcare systems, they're consolidating. You might see hospitals starting to merge more and more rapidly, and it might even have occurred here in Gainesville and in the Ocala area. And so healthcare is becoming more and more networked, and less and less individual hospitals are really kind of going at it alone. So let's think about that and how the pace of change and the amount of change that's occurring today. And then how, as leaders in healthcare, as policymakers, as clinicians, how can you adapt to that environment? How can you create positive impacts for patients, their families, and for your community? And so what I wanted to do is use kind of my experience at the VA, and I left the VA about 2 weeks ago, and I was the deputy undersecretary there leading the community care effort, and we focused a lot on the Veterans Choice Program. So I was going to give you a couple, use that as really as an example of how various leaders in healthcare can drive change. So in 2014, the VA was experiencing a lot of access issues, and that was kind of all over CNN and Fox News and all the newspapers. We just weren't able to, veterans weren't able to access care that they needed in a timely fashion. So as a result of that kind of crisis, that issue that was occurring, Congress passed what we call the CHOICE Act, or the Veterans Access, Choice, and Accountability Act. And so this act really provided the Department of Veteran Affairs with $15 billion, $5 billion to support kind of internal structure, hiring doctors and nurses to take care of patients, and $10 billion to partner with outside providers to deliver health care. From the very beginning, that program had a number of challenges. One, it had a 90-day implementation period. So it's a very short time period. I always compared that to the experience of TRICARE, which is another military type program. It took 3 years to get that program up and running. Well, VA had about 3 months to get the CHOICE program up and running. So very, very constrained time frame. Two, thinking about the department, the Department of Veteran Affairs has about 1,700 sites of care, about 150, 160 hospitals. So there's a lot of different health professionals across the country, all the way from Hawaii, Alaska, to Florida, New York. So how do you coordinate and communicate with all those different providers? How do you get them on the same page to move change forward? The law that was passed, the Choice Law, had a lot of different requirements. It required the department to behave in a different way than it ever behaved before, and very different than other programs that it had. So there was issues there in that it differed, and so things had to be different, and you need to be able to adapt to that. Next is communication. There's about 22 million veterans that live in the United States. About 9 million of them are enrolled in the VA. Those 9 million veterans, as part of the law, as required by law, had to get a card. It looks like a health insurance card, but not every one of those veterans was eligible to receive that benefit. So that created a lot of confusion. You got something in the mail that said you can get this benefit, but you really couldn't because you had to meet certain criteria that were stipulated. So how do you communicate with patients across the country and let them understand what those benefits are? Especially, how do you communicate when the criteria that are used change from day to day or are very hard to understand? And then lastly, infrastructure. Really the movement at VA with the CHOICE program is really how do you start to leverage some of the principles that health plans or health insurance companies had for many years, but as a healthcare system, the department didn't really have fully fledged. And so there was issues with infrastructure. So really that's a little bit of the challenge that the VA faced. And so when I kind of walked in I came to the department 3 years ago, but started working as the assistant deputy and then deputy undersecretary 2 years ago. These were some of the headlines that kind of I was faced with about the Veteran Choice card, all smoke and mirrors, Veteran Choice program having problems, the Choice program leaves veterans frustrated, clinics waiting for payment. And so again, all these different headlines about how the issues that are existed with the program. Now, we'll talk a little bit about the process that we went through to create positive change, but I'll tell you like up front that all the stories are not rosy now anyways, today either. So I think there's been a lot of forward momentum and positive movement, but we still have a way to go to get the program and really the concept of kind of internal and external care working well. So, you know, I'm one of those people that likes to simplify things. So when I was reflecting on how we went about creating change, I thought about, well, what were the things that our team did that really started to move the ball? And so they can really be summed up by an acronym, ACT. active continuous transformation. And I'm going to go over each one of those different words today, and that might be, hopefully, as you leave this, our conversation this evening, as a principle, as a framework that you might be able to use in your own circumstances of how to create change in healthcare. So first is active, which is really actively engage the right stakeholders in developing the future state. So this has been critical. It's very common for someone to come in and say, hey, I have all the answers. Here's what we need to do. Typically that's a way to kind of create a failing program. You really need to listen to your customers, to your stakeholders, to your patients, to the community about what they need. And so the first thing that we did is we started to think about how we can make improvements in the choice program and in community care, was actively engage our stakeholders. And I know our facilities at the department do this in their own right, kind of across the board. So the first thing you have to do is really identify who should you talk to. And so the VA community care team thought, well, we need to talk to veterans first and foremost. They are our customer, our patient. They're the center of everything that we do. We have to talk to VA staff and clinicians, so not just the nurses and the doctors, but also the administrators, the folks that are the clerks that are checking people in, the schedulers. We need to talk to veteran service organizations. These are groups that represent veteran interests across the country and might have pieces of information that we don't. And then community providers and healthcare leaders. We need to learn from other institutions that are doing this about, hey, what worked for you? Could this apply to the department? And so we really went through this process of really actively engaging and learning from all these different stakeholders and then listening. So that's really important. Take that feedback and put it to use. So what you can see in this map is we held a couple roundtables and a couple listening sessions, but we had our teams that really just went across the country, and really they were in those geographies anyways, and set up listening sessions and set up ways to actually what we call Gimba walks, kind of walk through the process. Let's learn what's going on. And so this was very important. We conducted interviews, site visits, data gathering exercises across the country to inform what the future state was. And so that was key. So we didn't come in preconceived, fully baked. We actually gathered information along the way. And what we heard throughout this process was, well, here's our issues. And we grouped them into 6 categories. Eligibility. At that time, our veteran patients didn't really know if they were eligible for the program or not. And which doctor do they go to, and do they need to pay anything if they go, and where do they go? So there's just a lot of confusion about, do I have this benefit or do I not? The referral process was very confusing. And the referral is really when you go from point A to point B. So you're going from one hospital to another or one clinic to another. Well, every one of these programs had a different way of doing that. So maybe one way you walked in with a piece of paper, maybe another way they had it through an electronic portal, maybe another way it was through a phone call. So it was very confusing for people to manage. Well, which way am I supposed to use? Care coordination was very challenging. And we talked at the beginning of our time today about multiple providers. Well, this is the perfect example of multiple providers. Not only are we making sure that we coordinate within ourselves, but also how do you work with other providers outside of these walls? Community care network. One of the things that we learned early on was how critically important it is to be good partners for your community providers. And that means making sure that they have all the information that they need, and for veterans, making sure that they have providers that meet their needs in their communities. Provider payment. This is key. If you don't pay well and if you don't pay on time, no one wants to work with you. It's pretty much basic business. And so we heard a lot of frustration as we did this, listening to different community providers and groups saying, hey, we're not able to get our accounts receivable or our bills paid on time, and we might not be able to participate if we don't do that. And then lastly is customer service. All these different programs created confusion. So how do you provide a service to not only veterans, but to physicians and staff and community providers to get their questions answered? So we kind of laid it all out there. Here's all the challenges that we're hearing today. And what we did is, again, when I kind of walked in is, well, where do you start? How do you start to tackle that? There's so much that you can do. So really what our team decided to focus on was, well, we are going to focus on the things that are important for veterans, and we're going to start working on those things first. And so we used a process called journey mapping, where you map a patient's journey through a specific experience. And so we looked at all the important touch points that they had as they went from the VA to a community doctor and back. And so we looked at eligibility, the referral process, care coordination, the providers they see in the network, provider payment, and then wrapped around as customer service. So we kind of committed to ourselves when I was there as a team that the projects that we're going to do, the work that we're going to do is going to touch veterans. And because it's so easy to get distracted and work on something else. So we wanted to make sure that everything aligned to the important touch points that our veteran patients told us was valuable to them. So the next is really thinking about continuous or continuously evolved capabilities of the enterprise to achieve desired outcomes. And so that's a lot of words. What does it mean? It really means is that change is not a one and done thing. You don't just implement a new program or you don't implement a new technology. You have to constantly evolve. The healthcare marketplace is constantly changing. The needs of patients and providers are constantly changing. And so what you want to do is make sure that you're constantly evolving and building capabilities. Capabilities will allow you to succeed in the future. It's very easy to just do a project here and there, but they don't all come together for the greater good. And so what we did is we really thought about how can we use capabilities to link vision and action. Again, when you think about, wow, there's all this stuff to do, well, I'll work on this, I'll work on that. If it's not coordinated, you really won't see that impact. And so what we did is we thought about, one, we have to start where we want to get to. The touch points that are important to veterans, that's the journey. Capabilities will feed into those key touch points, and then projects will be used to build those capabilities. So those are very kind of, it might sound simple, it actually takes a lot of effort to really focus the organization on working on projects and initiatives that build capabilities that drive towards those important touch points that your patients told you are key. And so this is really our capability framework that was developed at VA Community Care when I was there. It looked at each of the key touch points at the top, and then there's about 3 or 4 capabilities that the department had to develop to do that, to make sure that that touch point was successful and was satisfactory to our customers. So I'll use example eligibility. Really what we need to do is have 3 capabilities. We have to be able to determine if someone was eligible or not very quickly. 2, we have to communicate that. It might be through a self-service portal, it might be through the phone, it might be through information, and then we have to be able to track it as it changed over time. So again, very, very simple, but we were working on projects that built each of those different capabilities. I'll use another example of customer experience, which is we really wanted to provide education so everyone knew about the program. We wanted to be able to respond to inquiries in a timely fashion, and to be able to capture that feedback so that we could iterate and improve on it. So again, it's not overly complicated, it's not rocket science, but it's really focusing the energy. So all the different projects that the team worked on aligned to a touch point, aligned to a capability, and if it didn't, then we didn't work on it. And then at the bottom are really how you create what we call transformative program management. So how do you create change in a large organization? How do you deploy change? So Gainesville here is one of our pilot sites for a number of our programs that we did. So how do we take the lessons learned from Gainesville and apply them to Maine or to Montana or to Arkansas, and making sure that that works. So we have to focus not only on implementing in one healthcare system, but then taking that knowledge and be able to deploy it across the country. And then lastly is transform. How do you transform operations to standardized processes within defined guide rails? So what does that mean? When you think about these different projects, capabilities, not all of them might work in every single circumstance. So the balance that a lot of healthcare leaders, and really I think any industry has to kind of balance, is between standardization and customization. I always use this graphic. There's 14 competing standards. 14, that's ridiculous. We need to develop one universal standard that covers everyone. yeah, let's do that. And then what happens is now there's 15 standards. So it's very common to, everyone recognizes that there's an issue, and so they think that, okay, well, we'll just do it all this way. But then you realize that it doesn't work for this population, or you need to tweak it for this population. And so what's really important is how you create that balance. And what we use is something called guide rails and best practices. And so you want to be able to create guide rails. So you don't want to be overly prescriptive. You want to tell folks, here's the outcome that we want you to deliver, and then here's kind of your sandbox that you can play in. We want to inform that by best practices and say, well, here's 5 best practices that we identified across our system that are doing this really well that you might want to implement. And over time, you can actually shrink those guide rails even further and further and further as some of those best practices become more common. And so it's a very deliberate process, because if you try to overly standardize in a system as large as a department across 1,700 sites, when the care in Alaska is very different than the care here in Gainesville, you might not get it right. So you want to provide a little bit of that flexibility and that wiggle room, and then inform that by best practices that over time start to kind of standardize more and more. And so what we did initially to support that is to create a platform. What we realized is we couldn't push out changes to the system if not everyone was kind of using the same language or the same platform. And so over the last year or so, we've been rolling out what we call our local operating model for the Offices of Community Care. And so what that really looked at is how can a local facility organize themselves to succeed. And in order to do that, they have to have really, these are kind of the guide rails, really 5 key principles: clear roles and responsibilities, consistent processes that we shared, active partnerships and how you manage them, a standard way to do care coordination, and then very responsive customer service. And so we started to lay the foundation, the groundwork for what that operating model looks like. We want to get that in place, because then it makes it easier to iterate. If you have the same platform across the country, over time as new developments or new processes get improved, you can actually make those changes much easier. So think about it as, there's a couple industries today that we don't even think about but are standardized. So there's a lot of cameras and lights in the room. Well, they're plugging into a standardized kind of electrical port. So you can plug in many things into that electrical port. That serves as a platform. The same thing probably with a lot of your different devices. There's a common kind of USB type platform that you can connect different places. So there's a common framework or foundation that then you can use to iterate over time. There used to be an era in America where all the railroads were on different level tracks and gauges, and they couldn't really cross from one to the other until there was an effort to standardize that platform and then actually have connect all the different systems. The same thing was with the cable industry. There used to be different types of plug-in for cable, and now there's a standard cable outlet, and you can use any service, any product that you want. So having that platform is very important because it allows you to iterate over time, and that's something that, again, as we thought about how the VA transformed from being just a healthcare system to a healthcare network, there needed to be some platforms that weren't there before. So I just wanted to share a little bit of the outcomes. So what happened? And so over the last couple of years, what we've seen is a tremendous growth in authorizations for outside care and for appointments. And so between fiscal year 15, the end of it, there's about 300,000 authorizations. And an authorization is really what we call an episode of care. So we might have a woman veteran that is pregnant, so we send her out for multiple appointments with an OB and the delivery, and that would be counted as one authorization. It's a package, it's an episode. So each one of these authorizations can represent lots and lots of appointments. So at the end of 15, we had about 300,000 authorizations. By the end of fiscal year 17, about 3,800,000. So a lot increase, 13% growth. We also, our partnerships grew. At the end of fiscal year 15, we had about 175,000 providers in our system. A provider may be one healthcare entity. It might be by the end of fiscal year 17, which is really the end of September, we had about 460,000 providers that are working with VA in the community. That's 165% growth over that time. To give you a little bit of a sense of what we were working with, we had 6 law changes over this time period to the choice law. So it kind of tells you that there was some kinks in there. That's why we had to work with Congress to work it out. But those all led to important changes. The VA is administering its community care program through various network providers, and so these are really third-party agents that help us do some of our work. And so to maintain those relationships and to improve the care, those contracts have been modified more than 80 times. That's a lot. And then also to make sure that care is more seamless than ever before. 78% of our 78 locations across the country have some of our contracting partners actually embedded on those sites. One of the other ones that I'm that I think is not a lot of people pay attention to, but is very important. Over the last 2 years or so, the number of e-health exchange partners. So the e-health exchange is a platform that allows you to transfer health information between different hospitals and clinics and providers in the community. And so there's been more than 100% growth over the last couple of years, and now 1.3 million veterans are in these e-health exchanges, so that if someone walks into an ER and they really need to get some what medicines there are, they can ping the e-health exchange and get that information, and that number's only growing. But there's more work to be done, and so I think like I said, it might. I passed the baton about 2 weeks ago to the team to continue driving forward, and there's really 6 things that kind of continue to evolve the choice program and all of community care. One is a new law to consolidate programs and funding, and I think the administration has submitted a proposal that is now with Congress. 2 is network of best-in-class VA community providers. As we drive towards a reality or an era where healthcare is not just delivered within kind of 4 walls, but it's delivered in networks and at home. How do you identify those providers, and how do you make those providers, both inside the Department of Veteran Affairs and in the community, available to veteran patients to access? Timely payments to community providers remains and is still an issue for the department, and more work needs to be done there. Seamless health exchange between providers. This is really, I call it the glue in healthcare, and it's not only going to be for the Department of Veteran Affairs, but it's going to be for all of American medicine. We have to find better ways to share information. If we can't, then this whole idea of interoperability is really going to be an Achilles heel, because there's more and more settings and providers, and if we don't evolve from faxing over information or emailing over information to repositories of information that you can use for population health and data analytics and for caring of patients, it's going to be a problem. 5 is transparency on VA and community performance. There's been a lot of movement in the last couple of years from CMS, the Centers for Medicare and Medicaid Services, to report on hospital outcomes. But there's still a lot of opportunity to do that in the outpatient setting. And I think over time, the VA has really been a leader in this area of really sharing a lot of their health information, probably more than other healthcare providers. But we do need to get to a state where it's on equal ground, and there's more information that's available to consumers, to patients, to make sure that they are able to make informed decisions about where, when, and who they should receive their care from. And then lastly, improved care coordination and management. Again, that goes along with that information sharing. How do you coordinate care? More care is at home. It's in different locations. How do we make sure that no one drops the ball as a patient goes from one provider to another? How do we make sure that they don't get prescribed multiple medications that overlap and might have a patient safety issue? So these are really challenges for the Department of Veteran Affairs, but also will have our challenges for all of American medicine. So with that, I'll summarize, and then I'm happy to take questions from the audience, which is really, as we thought about as we think about all the changes that are occurring in healthcare, as we think about how to transform and capitalize on those changes to make positive outcomes, one framework that you can use is ACT, Active Continuous Transformation. And I think it could apply for in many different environments, but it's just a way to help you frame and conceptualize how you create positive change for patients and for communities and really for American healthcare at large. So with that, I'll end, and I'm happy to continue the dialogue with you.
Who is going to ask the first question?
Okay. Thank you very much for your very interesting talk. I have two questions related. Could the VA be considered a single-payer health system? And if so, how do we translate that to the whole country?
So, interesting question. So there's a number of healthcare entities in the federal government. The Department of Veterans Affairs is one of them. Other healthcare providers are the DoD, the military system, through their military treatment facilities and TRICARE, and then also Indian Health and the Department of Health and Human Services. So the VA is, the healthcare benefits are what's called discretionary spending. So they get an allocation every year from Congress to take care of a population of veterans. And so from that standpoint, there is one funder for veteran healthcare. The interesting thing is, about 80% of veterans have another form of health insurance. So when you think about the veteran population, a large chunk has Medicare or Medicaid or TRICARE or private sector care. And so that's kind of important to consider, because my experience when I was at the department is they might use the department for some things. They might want to get their hearing aid from the department. They want to get their eyes checked. They want to get their eyeglasses. There's an amazing pharmacy benefit, so they might want to get their pharmacies there. But they might want to get something different and use their other health insurance for that. So yes and no. I think there is if folks wanted to use the department completely, they can. But what we see is that there's actually a variation in behavior of what they use the department for some things and not for others. And that varies by location. And so I'll use an example of in some locations, like in Manhattan, it's very easy to get everything, whereas in Alaska or Montana, it might be further to get everything. And then two, it also varies by what we call at the department was service connected. And so if you have a lot of conditions that you develop during your time in service, you might end up being more reliant on the use of healthcare in the VA. Some of our patients with spinal cord injury heavily use kind of all services in the department, even though they might have more than one commercial public health insurance plan. So I think there's a lot that can be learned from the VA. The idea of integrating primary care and behavioral health care to address the social determinants of health that I mentioned early on, I think is very important. It's one of the few institutions in our society where you can actually, within kind of four walls, you can get housing assistance, educational assistance, and training through the GI Bill. You can get home loans. You can get benefits. And so the combination of those benefits with health care, I think, is very important as we think about how we take care of the whole person and not just their specific medical conditions. So I think that's something that's very important. I think for decades, the VA has been a leader in the electronic health record. They're really the first kind of institution to really populate that. I think there's room to grow now from there, but they have a lot of experience from how to leverage information to take care of patients. And then lastly, I think this focus on the veteran patient as an individual and not just as a transaction, thinking of them as a whole person and not just as they're coming in for diabetes and your condition. So I think there's a lot that the rest of healthcare can take lessons learned, and then also like vice versa. I think there's the VA hasn't really entered into the era of value-based medicine yet, and I think those are things that we can learn, or the department can learn from others. Thank you. Dr. Parker.
Thank you, Dr. Yehia. It's a proud graduate of our medical school.
Yes. So, my question is the component of the community part. You said, making certain patients are not overusing medication, side effects. How did you handle that, and is there a role for public health in that aspect of it?
I think that's, the infrastructure to handle that very well is just starting to develop. I think it's really where we need to go. One of the things that the department is doing is it's recapturing a lot of those different prescriptions so that unless it's an emergency, the way that the program is set up now, you get 2 weeks worth of prescriptions. So you might go there, you've got, you need an antibiotic, and so they're authorized to fill at any one of the different pharmacies 2 weeks worth of prescriptions. Anything that's a chronic medicine has to go through the very sophisticated, very highly rated from a patient experience perspective, the mail order pharmacies that the department runs. And so that helps a lot to make sure that we're not just having a community provider write a prescription and then the department's paying for that 30, 90 days worth, where they might also be getting it from the department. And so I think there is a role for that. I think the second part of your question about public health is important. As I just had mentioned before, many veterans have more than one form of health insurance. So even though they might be receiving care in our facilities, they might be receiving care that is purchased for them by the department, they can also just go and use their own health insurance and do what they want. So I think there is a role for public health, and I think you are seeing now more than ever before more states that are having registries, especially around the area of opioids and narcotics, where you can actually look into those different databases and see what's been prescribed. I think we need to evolve that so it's not just on narcotics and opioids, but it's on other conditions and treatments and drugs that play a role. We need an integrator. So we're getting healthcare from all these different components. So there does need to be something that puts it all together that's then becomes consumable for providers and for patients and their families to use.
Nice to see you back in town.
Thank you.
So, what do you think changed in terms of veterans' perceptions of the care they received as the community care program was building, expanding, changing? And the second part of it would be, what do you think is going to happen for the patient experience as we move more towards value and as the average patient has access to more data on quality of the care they're receiving?
That's a good question. So thinking about, when we first started measuring satisfaction with the community care programs, it wasn't great. It was the processes I was describing was very clunky and cumbersome. And I really didn't need a survey when I was in my former role to tell me that. You walk into a town hall and you hear directly from patients and from providers all the things that are not working well. That needle has been slowly kind of moving. I think I have two impressions from that. One is I think it highlighted for many individuals that were experiencing some of the care that's provided outside of VA's walls, and they were doing that compare and contrast, and they realized, hey, I'm getting a lot of value, and I actually have a very positive experience within the department. And so that came a lot, because usually they would marry the two together and say, well, I went into the choice program and X, Y, and Z occurred, but I had Dr. such and such at the department or at the VA, and they really took care of me. So I think there are a lot of folks who commented on really their positive experience. That kind of started to highlight it. I think too, the challenge that sometimes we face is how do you start to differentiate between what's a specific issue for the Department of Veteran Affairs versus what's a specific issue for American medicine. And so, finding appointments in primary care in a couple of the cities across the country is very hard. It's very hard to do that. And not everyone kind of connects the dots there. So I think, again, during my engagements with different veteran groups and organizations, they would bring up these stories of like, well, it took a couple months for me to get a dermatology appointment, and sometimes it does take that long in the community. So they were again comparing and contrasting the it too. Well, actually, my appointment to get that, while longer than I might have wanted it to be, was actually faster than what it was in the community. And then the last thing that I'll mention is, though, when it was working well, the community program was working well, because it does sometimes allow a veteran patient to receive care where their family's getting, they might not have to drive that far. And so, when it was working very, very well, those are a lot of positive experiences were there. So I think when I think about where I see potentially the future going is really this integrated system where you're taking the best of the VA has to offer and the best of the community and putting them together. I think in order to do that, that glue that I talked about really has to be very strong. Strong care coordination, good processes, good information back and good health care information. And then those, the process just has to be less cumbersome and easier to understand and use. Right now, there's way too many rules and laws, multiple programs do the same thing. It needs to be simplified. So I do think that there is a world where those two coincide. They're two sides of the same coin in my mind. But to make them work most effectively, you need those supporting structures in place. Hey.
I understand you have a background in HIV epidemiology and infection and things like that. So what is your view on how we can help target community needs for patients and populations infected with HIV?
So that's a great question. So my training and my clinical training has been in infectious diseases, HIV, and hepatitis C. And I think that population is very applicable to others across the country. It was one of the first that we really started to use these ideas of population health. Many different local and national agencies were able to look at how many new infections were coming a year, how many people were getting into therapy and into care, and how they were doing over time. And so some of those principles of how you actually deliver community health and population health, I think, came out of that HIV model. I also think HIV is a really good example of the patient-centered medical home. A lot of the care that was delivered in the early 90s and kind of at the start of the, as we started getting really good HIV therapy, was in this kind of patient-centered approach where you had not only medical care but also behavioral health care, you had social support there. A lot of those principles are what we want to apply today to diabetes and hypertension and cancer. So I think that model serves us well there. And then lastly, I think one of the things that when you hear HIV, I think in people's minds there's a lot of things that pop up, and it's usually not just a healthcare issue. And I think for me it reinforces why the social determinants of health are so important, because there's stigma associated with that. The society reacts many times differently when you hear someone has HIV than if they got diagnosed with cancer. Why is that? And so that really, I think, challenges us to think about how we can address that to make it work better. So really putting it all together, I think it's a good model for population health in general. I think it's really valuable to think about how we deliver kind of individual patient-centered care. And then I think it's also really a lot of lessons learned of how you can start to tackle the social determinants of health which is why where we are today, I think for many years now, we have very effective therapy, one pill once a day. It's easier for me to treat my HIV patients than to treat their diabetes. So we are in a very different place. And now really the thinking is more about prevention and really that community health aspect.
Excuse my casual attire, swim practice. I was just wondering, what does the day-to-day aspect of your job look like, and what do you think are the most rewarding and challenging aspects of what you do?
Wow, day-to-day. I don't know, like when I was at I'll answer. I've been at Hopkins now for 2 weeks, so my day-to-day right now is pretty light. Most people are just trying to figure out who I am and what I'm doing. But at the department, I think there's, I don't know if there's any day that's the same. There are a couple things that I did to kind of stay grounded and centered, and so I and I think many leaders do that, is I usually kicked off my morning with a huddle with my with kind of the senior leaders as part of my team. It's a skill that I learned when I was a clinician. When you're coming into clinic, you huddle with your nurses and your staff and see what does the day look like. And so I usually kick off my day with a huddle of what's hot, what's going on, what do we need to tackle. And then also I'm very focused on trying to make sure that we know what's the most important thing to accomplish. It is so easy to get distracted with a million things, and so we try to really challenge ourselves and to hold each other accountable and say, okay, well, we're going to get this thing done today, or these two things done today, and we do that. And then probably I spend maybe a third of my time on a couple different things throughout the rest of the day. One is really operational, in the weeds, figuring out how we can improve processes, how we can make, how we can shorten time to care, how we can improve satisfaction, how we can kind of connect the dots, how we can pay more timely. And then I spend probably another third on communicating. So whether it's with internal or external stakeholders, really communicating what is the change effort, where do we want to go to, where are we today, what are the challenges that we're facing. And then lastly is like strategic, which is really thinking about, well, what do we need to do now so that we can be prepared in 6 months, in a year, in 2 years. And so that's pretty much where I kind of spend most of my day. I think the thing that's most like challenging and rewarding, I think I've always been a people person, so I am usually always happy when I get to interact with veterans and patients, and so that kind of, I feel like you've done something good even just by interacting with those individuals, and for me they charge you up, so that's always a plus if I'm able to find opportunities throughout my day to do that. And then the challenges is, it's funny, a lot of people think the department is overly bureaucratic, and I think there's periods of time when that is, but when I was at the department, there was such a burning platform for change. Everyone knew that we had to do better and that there needed to be forward momentum. So I actually think there's a lot of things that got done relatively quickly. And so the things that were most frustrating though is that aspect. Well, every once in a while you hit a wall and another wall and you can't get things done. But for the most part, you're able to kind of get around some of those.
Thank you so much for being here tonight. Dr. Yehia will be around and will answer any personal questions that you have. And we have another program tomorrow night for any of you who are interested in history. Thank you again. Thank you to the VA and to you, Mr. Wisniewski, for recommending Dr. Yehia. Thank you.
Okay, if people could walk up to you and chit-chat for 2 minutes, please.
Thanks, Tom. Terrific job. I hope I represented you well.